welcome to this MedEClasses Grand Round on Primary Amenorrhea. And this is going to be a very interactive and interesting webinar in which we'll talk about 4 very interesting cases of girls who presented with amenorrhea and where we found to have a lot of issues in terms of assessment and diagnosis. We are really happy to have 2 of our colleagues who have joined from across the country. Dr. Sekhar is there, who is a practicing endocrinologist at Rajmundry, and he is working in the medical college. Dr. Sekhar, welcome on board. And,
good afternoon, sir.
Good afternoon. And he'll be presenting about a very, very interesting case. Then we have got Dr. Guru Prasad, who is part of the MedEClasses course and program as well. And he is practicing as an endocrinologist at Bangalore. Dr. Guru Prasad, welcome to the program. So we'll start off a bit with regards to the initial aspects of what is the common causes of primary amenorrhea, particularly with the angle of what we are discussing today about tall girls with amenorrhea. Then we will use those 4 cases to see how these practical assessment tips will help out. And all of these cases have quite unique issues which are there in terms of diagnosis and management, which we'll be covering from that perspective. So we'll start off first of all as to why it is important to evaluate for amenorrhea and what can be significant implications which can happen in that perspective. So I hope the slide is visible now. So this is a 17-year-old girl with primary amenorrhea who presented to us with stage 4 breast development and also a pubic hair development, and there was no menstrual cycle. So there was a normal development otherwise, but there was no periods basically. She was a tall girl. Now, this is a common concept which we'll talk about. All the 4 individuals we'll talk today were those who were either tall or had the potential to be tall, in that their bone ages were open and they had a delayed bone age in that perspective. It was found that the FSH level was high, LH was high, and estradiol was low. So our diagnosis was established basically of a hypergonadotropic hypogonadism and started on routine replacement therapy. Now, what happened on follow-up was a bit depressing, that the child actually developed a gonadoblastoma, and that was because a proper karyotype assessment was not done. And when we checked the karyotype, it was actually a XY phenotype. So it gives a big message that even if we have a classical feature of hypergonadotropic hypogonadism, we should look at karyotype. We have said that even if you have a child who looks entirely like Turner syndrome, even then karyotype is important because you may have a Y cell line. But if somebody is tall, then of course you want to talk about situations where you need to be very, very cautious in terms of assessment. So the theme today is about primary amenorrhea, particularly because of hypergonadotropic hypogonadism and tall individuals. So this basically brings us to a very narrow group, but a very important group of individuals who present to us with implications. Now, if we talk about primary amenorrhea, it's there around 2.5% of cases. Most of them would be physiological or functional in that perspective, but still there would be a significant number of pathology which we need to evaluate. Therefore, there is a need for meticulous evaluation in that perspective. You all can go and have a look at our website, learning.growsociety.in, where there are a lot of resources about pediatric endocrinology are available. Many of our courses are available in the form of fellowship and diploma programs, especially also for gynecologists as well as adolescent physicians. We routinely run 3 programs of PG lecture series and 2 grand rounds for the pediatric endocrinologist as well as pediatricians. And we have got publications which can be accessed both online as well as the hard copy, and our mobile application which helps making diagnosis very easy in that perspective. So the agenda for today is that we'll talk about 4 specific cases in a scenario where we have a girl who has amenorrhea with high estrogen. The second would be low estrogen and high androgen, an interesting case scenario. The third would be the issues with regards to whether there's a problem in the structure or the function, and then finally whether the gonad or the enzyme is defective. So these are 4 very interesting cases, all have common of having primary amenorrhea in a relatively tall girl with hypergonadotropic hypogonadism. So before we go that, we need to just have a touch base about pathophysiology of primary amenorrhea. So in that regard, we all know that there are 4 organs which are going to play a role: the hypothalamus pituitary as a unit, the ovaries, and the uterus. So all of them have to work in tandem to ensure that the periods happen. So we know that GnRH is a primary regulator of the gonadotrophins, which then synergistically add on the ovary. So LH acts on the LH receptor on theca cells to produce androstenedione, while FSH acts on the follicular, the granulosa cell, largely to produce aromatase, to produce estradiol. Now, both of them are synergistically required. What's important to understand is that in boys, LH is more important as compared to FSH. In girls, FSH is more important than LH. So abnormalities, isolated abnormalities in FSH or FSH receptor will cause a complete delayed puberty, no development, and primary amenorrhea, because you will have nothing, no follicle, nothing will develop. But abnormalities in the LH pathway, isolated LH defects, or if you have a LH resistance, will not cause primary amenorrhea. They will produce more like anovulatory findings in that perspective. If you put in the opposite perspective in boys, if you talk about abnormalities which are there with regards to the LH, you will have no pubertal development. So LHCG receptor defect, as we talk about, present to us with atypical genitalia, so very, very early and severe defect. FSH abnormalities will not have that much problem. You may actually have a high level of androgens, but the spermatogenesis may be defective. So just to put things in perspective, if you have abnormality in FSH, isolated abnormalities, you will have significant delayed puberty and primary amenorrhea. LH abnormalities may not cause that. Of course, GnRH and those problems will cause primary amenorrhea and delayed puberty. We will not focus that much on those groups today. Now, this estradiol is then converted from androstenedione via aromatase. So if you have a aromatase defect, you will have a sort of a situation in which androgens are high and estrogen are low. So the presentation in that scenario will typically be a child who has got some virilization at birth. Atypical genitalia will be there. The mother will also give you a history of hirsutism or virilization during pregnancy. And then things remain silent, and then later on they will present with estrogen deficiency in the form of delayed bone age and primary amenorrhea with delayed pubertal development. Of course, estradiol has to work on the estrogen receptor, and if there are estrogen receptor problem, you will again have problems which are associated with isolated abnormalities with regards. So if you have no estrogen action, the child will be born with a normal genitalia, because the default mode of development is a normal female. So zero estrogen action, normal female development will happen. Subsequent to that, the presentation will be delayed puberty, no breast development, and you will also have a problem in terms of amenorrhea. Now remember, because androgens are acting here, so your adrenal androgens are active, so therefore you will have a pubarchy which will happen in this scenario. So what I'm trying to do is to link up all this pathophysiology to clinical pointers which will help us reach a diagnosis in that perspective. Again, because estrogen is the major regulator of epiphyseal fusion, you will have a delayed bone age in that perspective. Of course, if you have a problem in the development of the uterus, particularly in the Mullerian structure, the upper 2/3 of the uterine, the vagina and the uterine development, you will have amenorrhea. These individuals will have normal breast development, normal pubic hair development, and they will have amenorrhea. So if you want to just assess clinically a girl who presents to you with primary amenorrhea, you have to look at three major things. What is the height? What is the breast development? What is the pubic hair development? And our algorithm will largely base upon this in that perspective. So abnormalities in the hypogonadotropic hypogonadism, that will be classical delayed puberty. Of course, you will have no development in that perspective. You may have pubarchy in this scenario because adrenal production is there. However, if you have a multiple pituitary hormone deficiency, you will also not have pubarchy. So pubic hair development is very important. Ovarian abnormalities like gonadal dysgenesis, the classical example being Turner syndrome with short stature, but many of the XY-DSD. So as discussed, XY-DSD is basically an act of omission, while XX-DSD is an act of commission. So something extra has to be done. So XY-DSD, any of the genes which are defective, they do not develop into testes. You will have a normal female development, which will happen. This will be associated with tall stature. As discussed, if you have a receptor problem, particularly the FSH receptor problem, you will have much more problems in terms of pubertal development. Abnormalities in aromatase will cause atypical genitalia at birth, followed by primary amenorrhea subsequently. If you have problem in the estrogen receptor, you will have pretty much a child who is a tall individual who has got reasonably high or an inappropriately normal level of estradiol. And then, of course, you have the structural defect. So primary amenorrhea can be because of a structural defect, like a Mullerian abnormality or rarely imperforate hymen. That is something which is easy to identify but often missed. So if you have a young girl who presents to you with acute abdominal pain, and you find an abdominal lump, look at the breast development and ask whether there is a bleeding which has happened earlier or not. So this is a cryptomenorrhea, an easy diagnosis to make, but it is often missed. Otherwise, structural defects will have a normal breast development and a normal pubic hair development. Then if you have a functional defect, that means that you don't have a production of estrogen. You typically have either too little estrogen or too much androgen. If there is androgen excess, also you can have primary amenorrhea, and this can happen in the setting of PCOS and CAH, and you will have hirsutism. Then if you have an impaired estrogen effect where you will have no thelarchy because there is no estrogen in that perspective. This can be because of resistance, which is estrogen receptor defect, where your estrogen levels will be relatively high, or you have a hypogonadotropic hypogonadism, central cause, or you have a high FSH, which is a hypergonadotropic hypergonadism. High FSH can be because of a XX DSD or a XY DSD. Remember, XY DSD can also have a similar manifestation. If the testis is not developed, it's damaged, it's vanished, you may have a complete female appearance in that scenario. The characteristic feature here will be tall stature. So as I said, tall stature means you may have XY DSD, as I discussed about the first case in that scenario. An interesting scenario is complete androgen insensitivity syndrome, which may also present to you with a girl with primary amenorrhea who has got good breast development but sparse pubic hair. So again, breast and pubic hair will give you the diagnosis in most scenario. And finally, you can have a biosynthetic defect. So if there is a proximal biosynthetic defect like star or side chain cleavage, you may rarely have salt wasting, but you may also have non-classical forms in which they don't have salt wasting. 17-hydroxylase deficiency will have hypertension, and aromatase will have hyperandrogenism along with tall stature. So 4 groups of disorders which will cause tall stature include estrogen receptor defect, XY-DSD, aromatase, and all these scenarios you need to be wary about in terms of assessment and diagnosis in that regards. So the key questions that a physician who is managing a child with primary amenorrhea has to answer is it amenorrhea? If it's amenorrhea, it's structural or functional, and what's the cause? Now, amenorrhea is classically defined as no menarche within 5 years of onset of breast development, or by 15 years of age you do not have, you have to start evaluating and working. So don't do unnecessary workup if it is not required in that perspective. The next question is structural versus functional, and for this you have to look at the breast and the pubic hair development. So if all the components of pubertal development is there and you have amenorrhea, you may have a structural defect. Rarely this may happen in the setting of somebody who was doing well, then develops an acquired cause of hypogonadism. So you may have a scenario in which somebody develops a brain tumor, somebody develops hyperprolactinemia, but usually if you look at breast and pubic hair, you will get the diagnosis. So this scenario, there is pubic hair development, but there is no breast development. It means there is a GnRH deficiency. So you have no estrogen production, no breast development, but because adrenals are working, this is GnRH deficiency, the adenarche is normal. If you have no breast, no pubic hair development, this could be a constitutional delay of puberty and growth, or it could be an illness, or rarely a multiple pituitary hormone deficiency, where also you can have a similar scenario. If you have a normal breast development with sparse pubic hair, you are usually dealing with androgen insensitivity syndrome. And finally, if you have a normal breast development, normal pubic hair development, and amenorrhea, look for malformation, and that becomes relevant from that perspective. And these are very, very important in that regards. So if you want to differentiate now from a structural to a functional lesion, In a girl who has got thelarchy and pubarchy with a normal estradiol, it's usually a structural defect. Go for imaging, go for other aspects in that perspective. While if there is a thelarchy which is absent, pubarchy is variable, you have to think whether there is a hypogonadotropic hypogonadism in that regards. Now we know that this is a functional cause, not a structural cause. The next question is, what is the cause? So the key things to look at examination include hirsutism. If you have a girl who had a normal breast development, normal pubic hair development, but has significant hirsutism, think that this could be PCOS. We have seen so many PCOS with primary amenorrhea as well. So this is something to look at. If, however, there is no hirsutism and no thelarchy, it means there is a complete hypogonadotropic hypogonadism. In this regards, if they are tall, think of a XY DSD or a estrogen receptor defect. If they have a normal breast development and sparse pubic hair, that is androgen insensitivity syndrome. If there is salt wasting as discussed, star, hypertension, 17-hydroxylase and aromatase, again, hyperandrogenism and tall stature, which will be there. So if you understand and look at the basic clinical parameters, you will identify these causes. So these are the various causes I've summarized. We'll go into individual aspects which will help us reach the diagnosis. So most important is that usually, if somebody is not having periods, you expect the breast to be not there. But if there is a good breast development, you are dealing with either androgen insensitivity or hyperandrogenism or structural defect. Easy to identify in that regards. Pubarchy, if it's absent, you are dealing with androgen insensitivity, hypogonadotropic hypogonadism. Basically, if it is a very severe growth problem, especially because of a systemic illness or a multiple pituitary hormone deficiency. Hirsutism will indicate hyperandrogenism, and aromatase will also be a part of that differential. Now, very important, that's what the focus today is, height. Everybody who comes to you with delayed puberty should be short. We say everybody with precocious puberty should be tall. If you have a short girl, think thyroid. Similarly here, if you have delayed puberty with tall stature, there is something wrong going on. You have to think of androgen insensitivity. Usually you're thinking of a XY individual. So AIS will come there. Any other XY DSD will come there, and aromatase and ES1. So these are the 4 possible causes of tall stature with primary amenorrhea, and we will be covering all 4 of them. So this is just a hint as to what cases we're going to talk about today. FSH usually will be high in most cases. If you have a low FSH, you're dealing with a central cause basically. And of course, estrogen will also give you a picture. If your estrogen is high and you have amenorrhea, your diagnosis is there of estrogen receptor resistance. So if you look at the breast development, the pubic hair development, the height, the hirsutism, FSH, you will get the diagnosis in most cases in that regards. And finally, to put it in perspective, if your breast development is not there, you're mostly dealing with the hypo or hypergonadotropic hypogonadism. FSH is high, you have to work up for further. Estradiol is low, look for gonadal dysgenesis. Very important, do a karyotype. If estrogen is high, you will think of estradiol resistance. If you have got low FSH, you are dealing basically with a case of a problem of central cause, go for MRI. And if you have, on the other hand, a normal breast development and you have got no pubic hair, this is most likely androgen insensitivity, go for karyotype. If you have got good pubic hair development and hirsutism is there, work up for hyperandrogenism. No hirsutism, look for structural defect. The key message is no breast development, no periods, hypo or hypergonadotropic hypogonadism. Normal breast development without pubic hair, it is androgen insensitivity. Normal breast and pubic hair with hirsutism, PCOS. Normal breast and pubic hair without hirsutism, think of a structural defect. So this case will be presented by Dr. M.V. Sekhar Reddy, who is an endocrinologist practicing in Rajmundry as assistant professor there, and the center of Abhiram Diabetes and Endocrine Center. And this was a very interesting case which Dr. Sekhar had actually discussed with me, and it was really good to get the diagnosis out there. So Dr. Sekhar, over to you. Please start the presentation.
Today I will be discussing a patient of primary amenorrhea with tall stature and with adequate estradiol levels. Coming to her history, a 20-year-old female, first in birth order, product of second-degree consanguineous marriage, who was born at full term, normal vaginal delivery, with no significant perinatal history. There is no history of any crisis or any atypical genitalia noticed at the time of birth, and with normal milestones, was brought by her maternal aunt with a chief complaint of no menstruation for the last 5 years. Coming to the history of present illness, there is a doubtful single episode of vaginal bleeding, which was noticed only as a staining of her clothes, following use of 3 to 4 cycles of OC pills around 5 years ago, and never had any further bleed after that. After this, the patient was continuously visiting multiple doctors and used many medications on and off for breast enlargement, but there was no improvement noted all along for these 5 years duration, and there was no history of any maternal virilization during pregnancy at that time, but there was history of death of younger brother at the age of 3 years due to a seizure disorder, and there is no history of any similar complaints in any other family members. And throughout these 5 years, there have been multiple investigations done, among which karyotype needs to be mentioned. It was done twice, and twice it was 46XX. So we can take it as a 46XS in this case. Coming to the examination part, general examination is normal, and her blood pressure is 116/80 in the left arm sitting posture. There is mild facial acne, and fine hair is noted over her upper lips, and her height is 176 centimeters with an upper segment lower segment ratio of 0.87. Her BMI is around 21, and breast tanner staging, it is almost absent, and pubic hair P4 and axillary hair is present, which is indicating that pubarchy is present, and there is mild clitoromegaly noted. In fact, it was due to her clitoromegaly that this patient was referred to me, and there were 2 orifices seen on external genitalia examination, and it looks clearly like a female external genitalia with mild clitoromegaly, and there is a gap between the first and second toe, and there is crowding of fourth and fifth toe with a short fourth and fifth metatarsals.
Okay, Dr. Shekhar, we'll just stop for a moment because this is a very, very important slide, and this will actually give us very strong clues which is there. So
Yes.
Clearly, as you mentioned, this is a tall girl who has got no breast development, no pubic hair development, with significant pubic hair development, which basically means that there is a discrepancy between the estrogen and the progesterone effect.
Yes.
So the possibilities which we are looking at, what would you think clinically from that perspective here?
Clinically, we think that there will be some estrogen defect, sir, whether it may be deficiency or resistance.
Yeah.
And internal pubarchy has taken place as there is pubic hair.
Yeah.
And at the same time, there is hyperandrogenism as there is clitoromegaly.
Yeah, so these are very, very important pointers. So what things we can really exclude out of here is definitely this cannot be a multiple pituitary hormone deficiency because she's tall and she's having a normal pubic hair development that is absent. Of course, AIS and all those things are anyway out because there is no breast development and pubic hair is there. Aromatase deficiency, do you think you can rule out here?
Slightly less for now at this time point, we cannot rule out, sir. It is one of the possibilities.
Yeah. So I think the key message here is that you've got good estrogen effect and lack of estrogen effect, while androgen effect is there or it may be exaggerated. So if you ask clinically to me, I would say aromatase could be a good clinical possibility in this scenario. And the height, however, is pretty tall. So that, of course, so basically, if you talk clinically, I would say we can narrow down to either estrogen deficiency or resistance. And deficiency, most likely, we are not talking about some, of course, most XX gonadal will not have that level of height. So that makes it a bit unusual. So as we discussed, there are 4 major causes of tall stature along with a primary amenorrhea. So AIS is out of that. Aromatase deficiency and estrogen receptor defect, yes, both of them are possible. And XY gonadal dysgenesis, do you think would be possible?
No, sir. XY gonadal changes less
So
likely.
that is also very, very, and you have karyotype, which is XX. So by the
XX.
time you have already narrowed it down to just two things, estrogen receptor problem or a aromatase deficiency. So I think that's the way that you took in such a wonderful history and examination. We can just reach to that narrowing of that. So carry forward from there. Yeah.
Yes. And this is my clinical impression after history and brief examination. We have poor estrogen effects as depicted by absent breast development and tall stature, suggestive of estrogen deficiency or resistance, and clitoromegaly depicts hyperandrogenism. And after this, I have forwarded to the hormonal workup. Her 8 am cortisol was well within normal limits, and we can see elevated FSH 40.88, and LH is also elevated, and we can see elevated testosterone 99.12, and here we can see estradiol is appropriate, that is 58.8 picograms per ml, and AMH is well within normal limits as is 17 OHP, and we have an elevated androstenedione, and the ratio of 17 hydroxyprogesterone to 21 deoxycortisol to the cortisol ratio is 0.33. As there is loss of feedback mechanism, we have an elevated FSH. And the basic biochemistry.
If you can please go back to the previous slide again, very important messages as you were saying. We have this hyperandrogenism. Now, this hyperandrogenism, why do you think it's happening?
This hyperandrogenism is happening because we don't have any feedback mechanism, sir.
Yes,
Estrogen in the hypothalamo-pituitary gonadal axis.
Yes.
So LH is stimulating this.
Absolutely.
Cells.
Yeah. So this is a very interesting scenario that your LH is also high, and that is driving the ovarian androgen production. So you have got this mildish hyperandrogenism going on. And when we say estradiol of 58, what we need to understand that we have a girl who has stage 1 breast development. Yes. So usually around 40, we start thinking that periods can happen. So somebody with stage 1, this 58 is pretty high. So this is in normally, if you talk about that way, it is not looking very high compared to a normal adult female. But for somebody who is B1, 58 is high, which means that there is estrogen resistance basically in that scenario. So I think this is a very, very important history examination which gives you the clue. Thank you. Carry forward, please.
After this, her basic biochemistry workup, including the fasting plasma glucose, postprandial lipid profile, and her calcium profile, and KFT and LFT were within normal limits. Then we move forward to look at the interesting part of her bone age. X-ray left hand wrist was done, and it clearly showed a delayed bone age, and her bone age is around 13 years, and her epiphysis was also not found to be fused. We know that we need estrogen action for the epiphysis to be fused, and ultrasound abdomen was done, which clearly showed very small size uterus, only with a thin rim of tissue visible, and importantly, both ovaries of normal size and echo texture, no ovarian cyst seen. And then MRI pelvis was carried out, which revealed bilateral ovaries of normal size and a hypoplastic uterus. And to see whether the estrogen effect is not there, we have also done DEXA scan, which revealed a Z-score of -2.2 at spine and -1 at left femoral neck. We know that estrogen has action on the cancellous bone, and that is the reason why there is osteoporosis present at the spine. So coming to the key differentials in this case, we have impaired estrogen action or estrogen deficiency as depicted by no breast and periods and tall stature and open epiphysis with delayed bone age and high FSH with hyperandrogenism as reflected by clitoromegaly. So if we narrow down, we have a 46XX karyotype and presence of Mullerian structures, which suggests possibilities like aromatase deficiency, which is supported by clitoromegaly, elevated testosterone and normal E2, low to normal E2, and estrogen receptor defect, which is substantiated by elevated LH and FSH, delayed bone age, osteoporosis, and normal to elevated estradiol levels. And very rarely, as we have distal abnormalities in this case, I had a DD of POR deficiency. And last probable differential diagnosis I thought was primary ovarian insufficiency.
Yes, I think these are very, very important differentials. And if you look at it now, if you go more in details, you have got the ultrasound which does not show a ovarian cyst. Generally speaking, POR deficiency and aromatase usually tend to have a large ovarian cyst. And for ovarian deficiency, I think the height is a big issue again. So 176 height, we have to think of either it's a XY DSD, difficult to explain from that. But I think this is absolutely very nicely summarized to the real point in that regard. So carry forward, please.
Now, genetic testing has been planned. Initially, clinical exome sequencing was sought to cover the genes that cover all the differential diagnosis. But then whole exome sequencing was advised as all the genes were not covered. And in this particular patient, aromatase gene sequencing also came negative. We had a defect of ESR1 defect. ESR1 is a gene which stands for estrogen receptor alpha, and they found to be a homozygous mutation located on exon 1, where cytosine has replaced adenine on the complementary DNA, leading to the shift of amino acids. So the final diagnosis in this case, comparing the history, examination, and biochemical workup along with genetic testing would be estrogen resistance syndrome due to the defective estrogen receptor alpha. So after this, I have reviewed the literature. There have been only 7 cases published till now, and 5 are in females and 2 are in males. All these 7 are from 4 families. The first case has been described around 1993 in a male. After 19 years after that, the first female case has been described in 2013. Then we have 2 sisters from Jordanian family with 1 brother, all 3 from single family, that is published in 2016. Recently, in 2021, there has been another 2 sisters having similar presentation. So all the females described till date had elevated gonadotropins and estradiol and amenorrhea, and multicystic ovaries, hypoplastic uterus, and poor breast development and tall stature, with delayed bone age and open epiphysis with decreased bone density. But except 1 case among these 5 females have sibling, which is actually a sibling of a case which has been detected. In this case, the estrogen has been only moderately elevated, and there are no cysts in the ovary, which is similar to our case. So this different phenotypic variation can be due to compensatory pathways that are mediated by estrogen receptor beta or G protein coupled estrogen receptor 1, or it can be due to the rapid non-genomic actions, and it can also be due to the pathways that are still yet to be characterized.
And what were the usual elevations of estradiol in other cases? Till what level?
It is more than 1,000, sir. In one case, it is around 3,000, sir.
Okay. So yes, so I think it may also be related to the severity of resistance. So there are so many other factors, as you mentioned, which can explain that. Yeah, yes, please, sir, carry forward. Yeah.
And the management is definitely challenging in this particular case. And in first case that has been detected, the patient was tried with conjugated estrogens and as well as with high dose estradiol, but both these treatment had no effect. And in the same patient, they have tried norethisterone, which reduced the estradiol concentration. This norethisterone, by decreasing the gonadotropin drive, it also decreased the ovarian cysts and size of the ovaries. This has been tried in the first case with only partial success, and in the second and third cases, they have been trying estrogen receptor alpha agonists like tamoxifen and raloxifene and clomiphene. They were tested to promote the transcriptional activity of the mutated estrogen receptor alpha, but unfortunately no effect has been found. Now the further studies are happening to act on the below pathways, that is below the receptor. They are trying to act on the co-activator pathways, like what's the therapy going on in the cancer. Still we can try high dose of estradiol in some cases.
So I think that's a very, very interesting case that you mentioned. And probably because your estrogen levels are not very high, if we raise it to a higher level, maybe there is a response. And there was apparently bleeding also, which happened in this case. That means that there is some estrogen responsiveness which is there. So this might be a slightly different spectrum, but a very, very interesting case. And as you discussed, the distal part, basically, which will be there, which are going to be affected from that perspective, which is something which we can treat out in that regard. So I think this was a very, very interesting case. The first question is from Dr. Shruti: how to differentiate FSH receptor resistance from hypergonadotropic hypogonadism? So this is an interesting scenario. So if you look at the way the ovaries are developed, if you have a FSH receptor resistance problem, you will have ovarian cyst. Multiple ovarian cysts will be there, which are there because ovaries will develop till that phase and then the problem happens. So you will have multiple cystic appearance which will be there, and you will have isolated FSH elevation. So that will be different from the primary gonadal failure. And this problem will happen right from birth. So there will be no breast development at all. FSH is mandatory for pubertal development in girls. LH is mandatory for pubertal development in boys. If you have a FSH problem in boys or a LH problem in girls, you will have puberty, but it will not be sustained. So if you have a FSH receptor problem, you will have complete lack of pubertal development. You won't really get confused with the typical picture of POI. Any differential resistance to estrogen with normal breast development and hypoplastic uterus? So what it means is that we know that there are different areas, the co-activators and the co-repressors, who work differently in different regions. So there may be variations, there may be different sensitivities, but if the receptor is defective, you will have the same effect.
More likely as an ultrasound report being reported as hypoglycemia. Very common that when you see a patient of primary amenorrhea, routinely the ultrasound report, more dedicated radiologists who would basically use, so they are not exactly a hypoplastic.
Yeah. So next question again by Dr. Shruti is: how do we explain endometrial thickness in the second case with untreatable estrogen? So I think Dhwani had mentioned that she had already received some estrogen from outside. By the time she came to us, she had been given some estrogen. And despite that, the bone age was 10 years. Despite getting estrogen, the bone age was 10 years. And there was, of course, some growth happening in that. Dr. Supreet is asking about the mid-parental height. So everybody was tall for the family. It was very, very clear. So they were pretty tall from the family. The second girl was not tall, but she had a delayed bone age. So that was aromatase presenting at an early age. But all the other three cases were tall for the family. It was very clearly from that perspective. And they were all in the male range, so to speak, in that perspective. So